So good evening, everyone. Thank you very much for attending and joining this webinar, Sochicar webinars titled TAVI Complications and Teamwork tonight. We hope it will be a great help to everyone, and we're looking forward to a great presentation as well as a very important discussion after the presentations. And this opportunity, we have two speakers with a lot of experience and a great trajectory in heart and structural heart valve disease. I will be joined with some panelists today, Dr. Nicolas Veas and Dr. Oscar Cuevas, who are interventional cardiologists and cardiac surgeon. And our speakers today will be international one. The first one is Adolfo Ferrero. Adolfo is an interventional cardiologist who is working in Instituto Nacional de Cirugía Cardíaca in Uruguay. Adolfo has a vast and extensive experience in structural heart valve disease. He completed a formal fellowship in Zurich with Dr. Maizano, and he's now working as a head of structural heart valve disease in his center. And the second speaker today will be Dr. Dimitri Kalabotriotis. Dr. Dimitri is a cardiac surgeon, and he's working at Quebec Heart and Lung Institute. He's specialized in minimally invasive as well as percutaneous procedures treating those structural heart valve disease. Dr. Dimitri has also contributed with almost 200 papers at the main literature in prestigious journals. Most of them are about structural heart valve disease and percutaneous procedures. So I'm really happy to have both today. And as I said, I'm looking forward for great presentations and a very interesting discussion after it. Because of a matter of time, we'll just start with first presentation, which will be from Adolfo. You can share your screen, please.
Yeah, it is supposed that you must be seeing it.
I can see your screen.
Yeah, perfect. Well,
we see your
thank you very much.
Thanks.
Thank you, and thank you, Dimitri, for showing me and in this presentation. We are going to discuss, as you said, TAVI complications. I will try to give my interventional point of view and how I think that the field is now be joined by surgeon and interventional, and we can bring for sure the close to the perfection for our patient if we work together. Well, there are some issues that I'm going to describe. The first, I will name the complication. We have the most frequent, of course, it is the site, the artery access complication is the most frequent. It carries with the transfusion and the hematomas and is the most frequent. Then we have conduction disturbances, coronary occlusion. We can have annular rupture, LVOT rupture, or chordal rupture involving the mitral valve, stroke, device embolization, or damage of the left or the right ventricle, depends on the side we are working in. How to try to avoid this type of complication? We are going to start with the puncture site. Well, who are at risk of having this type of complication? Well, if we are not lucky enough and we puncture the profund artery, if we have calcium in the anterior wall of the artery, if we have atheromatosis, calcification, and tortuosity, and all together, if our introducer sheet is more than 1-to-1 with the related to the artery lumen, well, women, obesity patients, how we can try to avoid this type of complication is, well, if we are well trained in guide the puncture with echo, or if we try to protect our access, I would say talk about the same side access or crossover protection, or if we leave the access in our surgical team, and or protecting both at the same time. We have this type of access. You can see easily that we are not, probably, you never know, but probably we are not going to have much issues with this type of access. You know, we don't have any calcium, we don't have tortuosity, we don't have aneurysm, and this dissection, all this type of issues that we can find when we are planning to access an artery. We can have this type of access when you have more tortuosity, extreme tortuosity like this, and you can see this takeoff of this profound artery. If you are not guided by echo, you can enter this artery. The wall is less strong, so you can damage easily. And well, you can find everything, but I am going to show you some things. For example, this type of aneurysm with dissection. You can try to fix a patient who was repaired previously. So you have the tubes here, you have dissection, a lumen in the true lumen. So you can have a lot of type of different problems. Well, you can see here aneurysm, dissection, well, all type of difficulties to try to fix this type of patient. Talking about the same side access that I mentioned before, you can use your main introducer and a second puncture to use your pigtail to guide your position, and then after all, you remove your main sheath, and if you have any trouble, you can fix this trouble from below. You are in the true lumen, so it's perfectly easy to solve. If you don't have enough space, you can just play the wire and to protect your artery to fix if you have any problem. Take a look at this case. We did with one of my friends, and you see that we have some issues here with near occlusion of the vessel, and then from below we put a balloon there and we solve the problem. You can have this type of big aneurysm in the aorta with tortuosity. Take a look at this patient. Of course, we can go through the groin if you are expert enough, but you can evaluate different access. We did this percutaneously. We access the subclavian artery. As I mentioned before, I am a great fan of protecting the artery from below. In this case was the radial artery. We did our case from there. We put our valve. You can see here, and this was the result. We were happy enough, and after moving on, we checked our artery. There was some bleeding here. You can see the stenosis and also a flap of dissection. We were protecting for this wire, so we put a cover stand in 5 seconds. We solved the problem. Of course, there is a flap of dissection that is going to disappear in a couple of days or hours. So we solve our problem. Of course, you can do this by a cut down. You can try to fix this artery with your surgical team, but you can do it also percutaneously. You see, this is most frequent that we think it is. We have pseudoaneurysm and bleeding outside or inside. Like in this case, you can go through the skin to the site of the bleeding, trying to fix this this leakage with thrombin, for example. You can use a lot of things, well, coils, a lot of different things. Of course, you can have your surgical team. They can do this openly, of course. Well, condition disturbances, I will go faster. You have certain things I'm going to explain clearly as a prediction of the problem. You can try to avoid having this problem, trying to put the valve very high, no predilation, trying not to do a lot of overstretching. Well, some patients need the pacemaker before. It happened to me a lot of times. You know, we have a structure there. You as a surgeon know it very well. You work with the heart, so you know perfectly, but we intervention cardiologists and the normal cardiologist has to learn a lot from these images. You have the septum here, you have the membranous septum there. It's a very thin structure. You can see we have light from the below to the heart, and no, we cannot see the light from everywhere, but from the membranous septum, it talks about the thing that it is, and it is close related to especially the AB band or the left branch. So if you put your device there and you have a right Vanderbilt branch like this, you are going to end up probably with a AB block, and that's why these images explain you very easily why having a right Vanderbilt branch block is at highest risk of having this type of complication. So the only thing you can do is trying to put your valve very high, trying to avoid a lot of overstretching or oversizing of your valve. I mean, if you put the valve like this, well, you did everything in your hands, so you can try to avoid this type of complication like this. It's not nothing special, a pacemaker, but well, it's a complication for us. Coronary occlusion is, well, something that we have to take a look very, very seriously, because it is, when you have this type of complication, you normally end up with the death of your patient, where the takeoff of your coronary below 8 millimeters, when your sinus are very small, the STG is small or low in terms of height from the annulus side, you have very calcified leaflets or very long leaflets or valve-in-valve situations. What you can do, well, a low implant, try not to expand the device very much, trying to protect the artery, and do a chimenea or a basilica. And you see, we have to face this type of scenarios very frequent when you have a long and very calcified leaflet and you push it against the coronary artery, so you can end up having a obstruction or an occlusion, and it is something deathly, as I told you. And you have to know very deep the device you are going to use. The device has skirt inside, outside, so you must know perfectly well the device you are going to use and the anatomy, of course. And while the devices are different, take a look at how we can try to predict coronary obstruction. You have a lot of different software. You can simulate. This is a valve-in-valve situation. You can see the post there and the annulus here. You try to simulate your valve there and the distance you have to the coronary artery, and also the distance you have to the STG, where they are below to the 4 millimeters. You have the high risk of compromise the artery with occlusion or or obstruction that are very, well, definitely, as I said. You can see here the valve they are positioning this valve. They have this anatomy. The coronaries were high enough, let's say, but well, they don't take a special look at the STG and the coronary sinus, and the valve for sure was bigger than they pretend. And you can see they have to solve the problem with the impella. They fix the artery, sorry. And after fixing the artery, I don't know why I have more than that. So here probably. No coronary, so they put an impella and they try to fix the artery. They were lucky enough to do it, but after all, they realized that they have a dissection here because the valve was bigger than the STG junction, so they break the wall of the aorta and they cause a dissection and the coronary, so they have two complications in one because of the planning. So you can see here that the annulus was about 24, and you can see the STG is less than that. So when you are thinking about your device, you have to take a look, a special look at the LVOT, the annulus, the coronaries, the sinus, the STG. All these structures are important because from this you are going to get the device which is safer for your patient. Well, annular rupture, you know, is something that is also cause the death of your patient. You can try to avoid doing oversizing. You know that the calcium is something bad, especially in the LVOT, and well, we have certain things that we are going to describe with images. Trying to avoid is planning. We have something that you know as a surgeon very deeply. We have a part of the annulus that we call vulnerable zone, which is surrounded by fat, not by other structures. So if you have any problem with the annulus in relation with the pulmonary tract, outflow tract, or with the left atrium or the right ventricle, well, you are going to cause damage. But if you break this vulnerable zone, you are going to end up having tamponade, and probably you are going to lose your patient because, well, trying to fix this part, you can probably, Dimitri can explain more deeply further on, and to say why it is so difficult to fix this zone and the complication. So if you don't have your surgeon with you, the patient have no time to survive. So we call this vulnerable zone. And well, calcium is something bad, but when you have calcium in different zones facing one with each other, especially if it is the vulnerable zone, well, you can end up having problem. Of course, you could try to solve this type of problem percutaneously, like they did there. They put some coils in the defect, and they were able to fix the problem. But it is, well, one case in 1 million. It is not that easy to do. If you have all your toolkit full of this type of things, you can try, but probably you must think about having your surgeon with you and try to fix it openly, because percutaneously is not that easy. This is the case I showed you before, And well, as I mentioned, they end up having a type A dissection, aortic dissection. So they fix the coronary, perfect, but then they saw that they have this hematoma and dissection, and this compromise the left ventricle, and they ended up with tamponade. So planning is something that you have to do perfectly. Well, that's the explanation why they break this thumb, because the valve they use. So, well, you must know your device and well, try to predict this type of complication. Well, embolization is something difficult to manage. Of course, you can prevent it. Well, having a good CT analysis, again, planning, taking a look at the calcium, and well, taking a look at the LVOT, and well, having a good pacemaker, positioning, and I'd say planning. You could be you could have this type of complication when you do a very fast inflation, and well, you lose the valve. You can try to do something to manage the situation, but normally you lose the valve. Take a look. They have learned from this complication. They started very low, and they have more control of the valve, so they were able to fix the complication. But well, the best way to fix it is try to avoid it. What to do if the valve embolizes? You can see here. If you are lucky enough, you can position again the valve. Try to do this maneuver is for specialists. I mean, you have to be very calm, maintain your pacemaker. Your second operator have to be frozen there with the volume in the valve, and well, you can try to fix this type of complication. Most difficult is to do what these people did here. Sorry, they have an embolization because a low implant, but the embolization was towards the ventricle. Well, they maintain the wire. You have to do it always, and well, they were lucky enough to remove the valve. I strongly said that you don't have to do this type of maneuver. Everybody's trying to do. I want to know the opinion of your opinion, German and Dimitri, of course, or Beas, trying to move the valve from the aortic plane to the descending aorta is something that is not that good. Well, they solve the problem putting another valve. I am against trying to move the valve. Take a look at these guys. They tried the same to put the balloon and to move the valve to the descending aorta. They got stuck there, and they have this hematoma dissection, and you can see easily that the valve or the part of the valve is outside of the artery. So if you have an embolization, you only have to take care of your coronaries and your patient coronaries, of course, and forget the valve. You can fix it with the snare in order not to move it when you put the new valve, but forget the valve wherever it is. It's okay. Don't try to move the valve is my advice. Of course, this was the previous area. You can see here, this is an apex access. They have an embolization, and they fixed the embolization, put in another valve. So they fixed the old valve with the new one, which is something they can do. Well, to have some numbers, you can see here what is happening when you have embolization. it is more frequent with self-expandable valves, and well, the risk of having trouble, needing a cardiac surgeon in your side is very, very frequent. So when the valve is not in the position you want it, so you end up having problem, and you must know what to do. And well, having your team next to you is something that I strongly recommend. You can see that the reposition is something probable, but it's not the most you can do. Putting another valve is something that you can do when the valve is in the aorta, but when the valve is in the ventricle, you can discuss with your team and the experience. You can put a second valve, but then you have to remove the valve that is in the ventricle. You don't have to move your wire because it is fixing the embolized device. And you can see that the mortality and the morbidity of the patient having a aortic or a ventricular embolization is very, very high. Of course, having a ventricular embolization is something that is, of course, more risky. Well, my main advice related to this talk is, of course, having your surgeon close to you. The people that are working with TAVR have complications. You must be prepared and ready to try to solve the complication. Some of these complications, I would say the vast majority of the complications are avoidable if you have a good planning. And well, if you don't have if you are not lucky enough to solve this type of complications, well, you must have your surgical team in your right or in your left, as I have my team. I work with surgeons inside in a cath lab. They are, as I told you, in my right, in my left, but they are with me, thinking, working, and trying the best for our patient. Well, thank you very much. I am open to, well, discuss any point of the presentation. I think I was close on time.
Well, thank you very much, Adolfo. Very interesting presentation. We have already a lot of questions, but I'm going to let all of them for after Dr. Dimitri's presentations. So yeah, thank you.
You're welcome.
Dr. Dimitri, you can share your screen, please.
Thank you, Herman and Adolfo, for the excellent presentation. Can you see my slides?
Yes, perfect. We can see it.
Okay, great. So I think what a lot of the points Adolfo presented are extremely valid, and I agree with everything that was said and presented. And I'm going to try to take a little bit of a different kind of a philosophical approach to TAVI. And oops, sorry, I'm on call. I'm just going to have to turn this off. To TAVI and TAVI failures. And what is the role of the cardiac surgeon in 2023? I'm going to address a little bit arterial access issues like Adolfo mentioned, which are, I guess, the most common and also the least dangerous. I'm going to also speak about alternative access because I think it's important. And for patients that are not candidates for TF, I'm going to speak about aortic annular rupture, which is a very catastrophic complication. Luckily, it's extremely rare. And also TAVI explant, because as we're moving to lower risk categories, TAVI explant as a surgical procedure is going to become a reality. And I think surgeons have to be extremely facile and aware about the challenges of explanting a TAVI in these patients. So I don't have any significant disclosures. I think Adolfo mentioned this, I think TAVI complications are best divided into peri-procedural and post-procedural. I won't be really discussing post-procedural. Adolfo mentioned a few of them: cardiac, access-related, prosthesis-related complications. So I'm mostly going to focus on peri-procedural. This is a slide from Thomas Walter in Germany, who said, and he's extremely right, and Adolfo mentioned this, I think preparation is key in avoiding complications. So we have to focus on avoiding complications and not bailing out TAVI patients, because the bailout strategy, as you know, can approach 30 to 40% mortality, which is high. But if you look at it on the other side, that's 70% of survivors that have undergone bailout. So bailout does have a potential to save lives. So that's also important. This is an extremely busy slide. Nobody understands this slide, but I'm gonna try to explain. This is a paper we published this year, looking at the importance of the heart team. Okay, the heart team is extremely important. Cardiac surgeons with interventional cardiologists, a variety of other clinicians may be involved as well. And this, we looked at the results of SAVR, so surgical AVR, for patients that were originally referred to TAVR and originally referred to the heart team. So all patients referred for TAVR go through the heart team, and then we decide, well, between 2007 and 2016, 528 patients were referred for TAVR, 340 underwent TAVR, others underwent optimal medical therapy for a variety of reasons, and 188 patients actually underwent surgery after they were referred and evaluated by the heart team. So when we looked at patients that went through the heart team versus SAVR patients that went directly to surgery, we see that there's actually zero mortality in the patients referred to the heart team versus 6% in the non-heart team group. These are SAVR patients. So what does this mean? I mean, the heart team has tangible benefits in the real world, and 0% mortality in the heart team, but also there was a variety of lower adverse events such as strokes, low cardiac output state, re-exploration for bleeding, even pneumonia. And why is this? Well, several hypotheses can come to mind in that the heart team not only optimizes patient selection, surgery versus TAVR, also optimizes arterial access, and selects for the best arterial access for the patient. And also we can, optimize these patients medically before going to surgery or TAVR as well. So the heart team is definitely a good thing. And all patients referred for TAVR are discussed via our heart team of 3 interventional cardiologists and 3 cardiac surgeons. Sorry for the quality here. It's not the best, but this was obviously the access is not ideal here. I would probably say that this patient should not have undergone a TF, but this patient did undergo a TF at our institution. And this was the final result, so after the sheath was withdrawn, there was a severe stenosis of the common femoral, which was balloon dilated after passing a wire down. But the final result was not optimal. So we were left with this. It was very hard to pass a small, I think it was a BMW down there, and get the artery dilated. Finally, the patient ended up with an interposition graft. And you can't appreciate this, but this is under the inguinal ligament. So this is the external iliac. So it's actually quite deep, and the patient was quite big, and the common femoral is there. So as Adolfo mentioned, arterial access issues and complications are present. They happen. They luckily we most of these patients have good outcome, and we're not really worried about them. But they do happen. Perclose sign is another situation. This was a patient with actually perfect access, but after tying down the 2 perclose, well, they had that stenosis, which was then balloon dilated, and the patient did okay. But as we move into younger and younger patients, these kind of things, we really have to take them seriously. And I think perclose sign is only as prevalent as how hard you search for it. So I don't know if people inject afterwards or just look at pulse. But if you look for a perclose sign, you will find a perclose sign. In an 85-year-old, this may not be relevant, but it's certainly in a 60 or 70-year-old lower risk patient. I think this is a very important complication. So this is a paper, an editorial we wrote with Josep and Siamak, who's Josep is an interventional cardiologist, and Siamak is a chief of cardiac surgery here. And really, I think in avoiding vascular complications is you really have to fit the access to the patient and not the patient to the access. You know, if you're doing 95 to 100% TF, there's either complication rates are either you're exceptional and your complications rates are low, or these patients with prohibitive iliofemoral disease are not being referred and they're not undergoing TAVI. And as we know, medical management of severe AS is not a good thing. So really, we have to choose the appropriate access for the patient and not try to, you know, force everyone into TF. So I think that's the key. Really, this is the key to preventing vascular complications in really finding the best access for each patient. So I'm going to mention alternative access in 2023. Do we need it? And the answer is absolutely. We do need alternative access. And I mean, by alternative access, I mean patients who are not candidates for TF, okay? Patients who are not TF candidates. We know in the trials of intermediate and high risk that transapical and transaortic were associated with poor outcomes. In fact, all the benefit of TAVI was lost when the approach was transapical and transaortic. So that kind of led us to find, well, we need to find other less dangerous accesses. And really in here in Quebec City, transcarotid, and this is one of our previous fellows, Dr. Shamani, who presented these data, transcarotid has really become our main alternative access of choice in 2000. We started in 2015 and we've done about 400 cases, and I'm going to show you some data for the transcarotid access. So it's our, for non-TF candidates, we prefer the carotid artery as our secondary, as our alternative access. This is an algorithm, and we've published this as well, that we use. So obviously all patients referred for TAVR are assessed for transfemoral access. If they're not candidates for TF, then we assess them for TC. Common carotid greater than 6 millimeters. If there's no contralateral or internal carotid artery stenosis and no significant tortuosity, then we go TC. If there is, then we look at transsubclavian. Now, if there's an ipsilateral and patent internal mammary graft, then it's problematic, and then that's when we go down to transaortic. If they've had previous cardiac surgery, porcelain aorta, as a last resort, we go to transapical. And we've done a lot of transapical, but it's really our last kind of resort. So really, we don't really, for the patients that are not TF candidates and we're looking at them for possible transcarotid, we don't really do brain imaging and a peri-procedural perfusion assessment. We used to, but we don't do that anymore. So you don't need to establish the integrity of the circle of Willis before undergoing a transcarotid procedure. Okay, this is, so we compared basically transfemoral with transcarotid, and we did what is called propensity score matching, which is a way to adjust for discrepancies in the two groups. And really, transcarotid patients are the sickest patients in the hospital because, as you know, they have obviously a lot more peripheral vascular disease. They have a lot more coronary artery disease, COPD and diabetes and transfemoral. So we attempted to adjust for these differences. And what we found when we look at transcarotid versus transfemoral, actually the stroke rates are comparable, procedural success is comparable, life-threatening bleeding, vascular complications, and mortality. Mortality was a little bit higher in the TC patients, but this was not statistically significant. But obviously these patients, the TC patients, are much sicker than the transfemoral. And long-term results are actually maintained out to about a year, and we continue to follow these patients. So we've done about 400 TC. Procedural mortality was low with a stroke rate that was under 3%. Pacemaker implantation was no higher than the femoral, and life-threatening bleeding and vascular complications were low as well. Pitfalls when doing a TC procedure, and this is, we do these as cardiac surgeons. You do not need vascular surgery to do the procedure. We're fairly comfortable with exposing the carotid, given our experience with type A dissections and so forth. Hematoma is extremely rare. What I do is I leave a drain in. You can leave a small caliber drain in and take it out on day one. A vascular injury needing further reintervention was rare. So in 11 cases out of 400, this was early in our experience. These injuries needed patch repair in about 7 patients, a short interposition graft, and all these were performed, and all these were recognized quickly and performed during the TAVI. So what I do now is I'll show you a short video of our TC procedure. We pre-dilate the artery with a dilator, and when you remove the introducer, I clamp proximally and distally and do an intima to intima repair. So I want to see the arteriotomy closure under direct vision. I don't just remove the introducer and tie down the purse string. I think that's dangerous because you can create an intimal flap inside, and you don't want that. We usually, if you're doing a Sapien 3, you can use the certitude system, but you can also use the commander system if the artery is small. Okay, the commander system is feasible, and we've done it through the carotid as well. Obviously, all platforms are amenable to transcarotid, and commissural alignment by the carotid has been described, and it's been published, and it's feasible, and it's extremely easy, both for the Evolut platforms and for the Boston valve. So dysphonia is extremely rare. You really want to, for the surgeons in the room, you really want to open the carotid sheath and to avoid injury to the nerves in the surrounding the carotid. So you don't want to clamp those nerves, and mouth drooping of the mouth is extremely rare, and it's very important to make an incision very low in the neck. So if you're seeing the bifurcation of the internal and external carotids, then you're too high. Okay, this is not an endarterectomy procedure. You really want the common carotid, and so we've largely abandoned transubclavian because the carotid actually has a very low rate of severe tortuosity calcification, and small diameter carotids are rare. If you look at a patient with extremely advanced iliofemoral disease, look at their carotids, and you'll be very surprised to find that the common carotid is a privileged vascular territory. It's actually free of disease in a lot of these people. You can use the carotid if there's a patent Limata LAD graft, unlike the subclavian. And in about 15% of our cohort, of our transcarotid cohort, morbid obesity was the only indication for transcarotid, with an extremely huge pannus, and we were afraid that the perclose wasn't going to work in the femoral root. So 15% of our transcarotid patients had only obesity as the indication for going via the carotid. I'm going to forward this. I think it's a couple of minutes. So we use brain saturations during, this is a transcarotid case. And so an incision very low in the neck, this is the sternal notch right here. Okay, so your 2 to 3 centimeter incision is all you need. I have not done percutaneous transcarotid. It's been described. I have not done it. Patients are under general anesthesia. We've done a few under local anesthesia. You can do it under local anesthesia, but we prefer to use general anesthesia for transcarotids, given that you're so close to the patient's mouth. So the angle between the sternocleidomastoid and omohyoid is where you'll see the carotid. And as you can see here, it's extremely soft. And we expose the carotid and control it proximally and distally. And so we can, close the arteriotomy at the end of the case. We put a purse string in, especially for the Evolut system, because there's a caliber change in the catheter, so you can tighten the purse string during the case, but we don't use this purse string to tie after the introducer is removed. So, and then basically the next few steps are extremely simple. Sorry, I'm just going to fast forward this here. Yeah, and this is what I mean at the end of the case. So after the introducer is out, you really can appreciate the intima, and again, this is a cardiac surgery. We do this as cardiac surgeons. You don't need vascular surgery, and then we leave a small drain in. And we infiltrate with Marcaine, so the patient has minimal pain. Annular rupture, I wanted to mention a few things. Adolfo mentioned about annular rupture. It's a devastating complication. Despite our best efforts, mortality is about 60 to 70% in the literature, and at our institution, we've had about 11 cases with only 3 survivors. Risk factors, are small women with a small BSA, a high calcium score, as Adolfo mentioned, and the calcium distribution is also extremely important. If the calcium goes down into the LVOT of a small valve, you have to be extremely careful. So post-dilatation also can be a risk factor. The treatment, as Adolfo mentioned, I think is early diagnosis, and you can see an echo here with periannular thickening. This is a transesophageal echo, so the probe was put in after the patient was intubated, and very rapid execution. You need a pump that's ready. You need a surgeon in the room immediately to do the sternotomy and go on bypass. That's the only way to save a patient. If you're waiting, if you're trying to kind of percutaneously manage the complication, the patient will not survive. Root replacement is, at least in my experience, is necessary in about 60 to 80% of patients, because you go in, and as Adolfo was saying, right at the junction of the right and left, that's where the tear usually happens, and that is extremely difficult just to patch and put a valve down. You probably, because it usually goes under the left coronary, and you need to do a root replacement in these patients, and it's a tough operation. I ask 2 surgeons in a room to really do a fast operation, because you don't want to be clamped for 2 hours in these cases. That's the only way to save lives here. Sometimes you can get away with just doing a patch, especially if it's at the non-coronary sinus, and you can do like a Y root enlargement, and that's been described. Just put a patch down and then put a valve in, so you don't have to do a Bental. But that's the minority of cases. I want to mention a few words in my last couple of minutes, and I just have a few slides left. I want to mention a few words about TAVI explant. This is going to be a big issue in the future, because we're doing more and more younger patients, and things like endocarditis are going to be happening. Things like subclinical leaflet thrombosis is going to be occurring, as you can appreciate in this slide. And of course, valve degeneration, that's going to be a very important thing. So I think all young surgeons have to, and we have to train our fellows to be facile in TAVI explant, because they're not necessarily easy operations. This was published. We participated in this multicentric study. Mean age 72. So approximately 200 patients at 13 months were explanted. There was an equal distribution of balloon expandable and self-expandable, mostly for endocarditis, but also for structural valve deterioration. So the important thing is that about 15% of these patients require root replacement. Why? Well, as you can see here, when you remove the valve, either it's a sapien or a core valve or other valves, obviously you have this invasion of the intima into the valve, and as you take it out, you just tear the whole root apart. It's very hard to establish a plane and avoid a root replacement. And what's the mortality for these patients? Well, it's about 12%. So it's not bad. I mean, considering that a lot of these patients were non-operable in the index operation. But we really need to improve these numbers, I think, as surgeons, and really get very, very kind of facile and TAVI explant, which I think in the future is going to be a very big deal. So the take-home messages, I think, as Adolfo was stressing, teamwork is key. And you need surgeons, you need interventional cardiologists. I think we both have different skill sets to contribute to these patients. And this collaboration really starts at treatment selection, SAVR versus TAVR. Okay, so surgeons are involved, cardiologists are involved, even for selection of therapy, selection of prosthesis type, and of course to select access. So all these patients, as CAT scans are looked at by both disciplines, and we select TF for most of the patients in our center is 80% TF, 20% alternative access. So we have very few TF complications. We have hardly any, because we have a low threshold to say, well, this patient is not going to be optimally managed by TF. And obviously, surgeons and cardiologists are well equipped to deal together to ensure an optimal outcome when a catastrophic complication arises, because what you want at the end of the day is a live patient. I think alternative access for non-TF candidates is essential in 2023. And if you develop a strong alternative access program with excellent results, you will expand your pool of TAVI referrals. You'll get the patients who are probably not referred because of occlusive iliofemoral disease. And in our experience, as you can see by the data I presented, transcarotid access is a safe and effective access with high procedural success rate and good clinical outcome and a stroke rate that's similar to TF, despite an extremely higher burden of disease in transcarotid patients. So this is the heart team. This is a very old picture because I had very little gray hair here, and now I'm almost all gray. And these are our two interventional cardiologists and Dr. Mohammadi and the fellows who come from all over the world to train with us. And we're extremely pleased to have them, as we were pleased to have Herman. Herman was with us. This picture was taken a year and a half ago. This was, I believe, Herman, it was your last TC case with us. And I invite everyone to visit Quebec City if they have a chance. It's a nice town. And thank you very much for giving me this opportunity to present.
Thank you very much, Dr. Dimitri. Outstanding presentation as usual, and very nice pictures, especially the last one. Yes, it was my last TC TAVI before I came here to Chile to work with my great team now. So we'll start with some questions. We'll let our panelists to start with questions if you have it, and if not, I will start with other questions from the audience. I don't know, Oscar or Nicolas,
yes,
do you have questions?
I have a question to Dimitri. His excellent presentation. When Alberto Barria arrived from Quebec to Chile, he started talking about the second approach by carotid. For me, was like this guy is crazy. Our second approach in Milan, where I performed my fellow, was the axillary approach. So the data in carotid is quite good. We have only one case with a vascular surgery that performed the artery. But you, in your algorithm, you didn't say nothing about the transcaval. What do you think that the transcaval?
Yeah, transcaval. We've never done transcaval in Quebec City. I know a lot of people have experience with it, and even in Canada, there's they do it and they like it. I personally, this is my opinion. This is only opinion. I don't think transcaval has a huge future, to be honest, because when these patients have iliofemoral disease, the descending aorta is calcified, so you need to find a soft spot. The residual fistula then ensues, even though people say it's of no clinical consequence, always kind of worries me, and the device that they have to put in to fix the fistula. People may be in disagree. I don't know in South America if you guys do transcaval. I know in the US a couple of centers do, but I don't think it's going to end up being a competitor in terms of alternative access. That's my opinion.
Well,
Oscar?
I prefer transcaval before transapical. Do you agree?
I think transapical is last resort. Is a last resort access. I agree, but I think transapical, now that the introducers are smaller, and transapical is a much safer procedure than it used to be when the initial partner trials were published, which basically said that doing a transapical procedure was like murdering the patient. Okay, that's what the partner 1, partner 2A show, but that's not the case anymore. Okay, because we have smaller introducers. Patients are well selected. I think to my knowledge, transcaval versus transapical have never been directly compared, but it would be an interesting comparison.
Yeah,
Oscar, you can make your question.
Yes, first of all, I am super agree. The transapical devices are now much safer than before, and we could see the Tendyne system that is now having a lot of fans around the world, because transeptal mitral is still developing. And regarding to transcaval access, I've done 7, And as you say, the problem is not all the process, because it's very easy to do it. But the problem, as you say, if the patient has really sick femoral arteries, the most of the times has really sick abdominal aorta, so you don't have a right sweet spot to do the cross. And I want to say happy birthday to Adolfo Ferrero. He's today birthday, 21st of September.
Thank you very much, my dear friend. I fully agree with this. Transcable, I think it must be considered is something time consuming. You need well, a different toolkit, well, experience, of course.
And
but
expensive. You need to put a plug to the final.
Yeah, it's expensive. Yeah, you are right. But it is something, well, I would say safe, but I fully agree with Dimitri. The data that was published in the partner were taken from surgeon that probably were learning how to do it, because as a cardiac surgeon, they don't have to do it frequently. So I think that the technique has improved. They don't use small stitches, they use the bigger one. So there are a lot of things that have changed, and I have the experience with the transapical and good cardiac surgeon, and the access to the apex was really fast. How they manage when we remove the entire sheath was so fast and quick, and the patient did that well that I think that we must consider this access. But I fully suggest to have a good interventional cardiologist for transcaval access and a well-trained surgeon to do the transapical.
Excellent.
I fully agree with that. Yeah, 100%.
I think it's very
Adolfo, can you, okay?
I think it's very important to understand that the surgeons must be involved in the program, and this really make the results better, because it's different to have a surgeon that comes just for do transapical access, like we do for venting in a transplant, for example, that a surgeon that really understands what you're going to do. So that's the reason that you need to involve and work together, I think.
Well, I fully agree. You know me, Oscar. We are close friends. But now I have my surgical team working with me. I mean, so we are a team. They are not my team. We are a team, and they are with us in all the entire process. So we select the patient together from the consultation. So we did consultation together. We see the patient, the family. We talk with the patient about the risk of both procedures, but clearly and without any bias, because he explained his procedure, we explain our procedure together. So we leave the family and the patient to take the decision. And then the entire process, which involves see the test, CT analysis, and the planning, they are very involved with the decision. So we know very well the patient we are going to treat, the strategy. The strategy was discussed previously. We all agree. So I think it is the way to do. It's not having a hard team with the surgeon there making opinions. Sorry. So I think that the team must be involved in the entire process to select the patient and to do the case, and of course to be involved to take the worst decisions when complications come.
Yeah, I mean,
think-
that's extremely important. I think you mentioned it, Adolfo, that it's also not a technical collaboration. It's also an intellectual collaboration, because this field is changing. It will advance, and I think both parties, both disciplines, have a lot to contribute to the advancement of this field. As you know, valve and valve is interesting because there's a lot of candidates that are not candidates for valve and valve, and surgeons. Years ago, we put a lot of tissue valves in young patients, thinking, well, TAVI is gonna save us. And there's a lot of patients with VTCs that are suboptimal, and small valves, and Basilica is a good procedure. I believe in it, but I think for the future of structural, especially as with regards to TAVI, I think only hospitals that have a good collaboration will have not only optimal outcomes, but will ensure that this field moves in the right direction and has the best outcomes for the patient.
Dr. Contreras?
Fully agree.
Quería, primero que todo, agradecer a los participantes y quería también incitar a las personas que están participando del chat a poder hacer sus preguntas si quieren en español. I want to say thank you to Dr. Adolfo and Dr. Dimitri. And my question is about how should we confirm the ideal heart team? Because we know the number of TAVR is increasing every day in the world. And we have to choose the perfect valve for each patient. Sometimes we try to copy like the state, but we are Chile, not the state. And sometimes the resources are not the same. How do you work? How do you, every week, everybody take position? And the other thing we know is if you have to do a TAVR explant, the mortality associated is around 70%. And if we do a surgical valve, the risk of that is 4%. La pregunta es, en el caso de los pacientes que tienen, ¿cómo funciona el heart team? ¿Cómo está compuesto? Porque el número de TAVI está aumentando y obviamente los problemas asociados también. Entonces, ¿cómo se conforman? ¿Cómo lo hacen? ¿Cómo sería la manera ideal de participar el heart team?
Adolfo, did you want to go ahead, or do you want me to start?
No, you.
So the heart team has existed ever since we did our first TAVI in 2007 here. It's composed of 3 cardiac surgeons and 3 cardiologists. They've changed, it's changed somewhat in the past few years, but we meet once a week for 1 hour, and every single patient referred for TAVR is discussed there. Every single patient referred for TAVR is actually seen by a cardiac surgeon and a cardiologist. And usually, sometimes we may disagree on what approach to use, but disagreements are rare. Okay, for patients who are equally, I guess, manageable by either therapy, and I would argue that those patients are actually rarer than we think, because I think the lifetime management of AS is an extremely interesting thing, and it's an extremely dynamic thing that changes every day. So especially for younger patients who may have bicuspid disease and bicuspid arteropathy, we discuss these patients individually because there's no clear answer. Not in the guidelines. They, for instance, younger bicuspids were excluded from the randomized trials. So all of these patients are actually discussed, because the overlap is, I would argue, is not that. By overlap, I mean patients that could be equally managed by both therapies. I think it's open to discussion, and we discuss these patients individually. And it's extremely rare to say, well, this patient satisfies 100% the guidelines, either European or American or South American guidelines for TAVI or for surgery. I think these patients are discussed individually, and I know the volume is extremely high. If we don't finish reviewing the 20 referrals we get per week, or 25, then we meet between TAVI cases. We do 9 TAVIs a week. And we're trying to increase those numbers. We're having bed issues as a problem, but we discuss between cases, and the volumes are increasing, and we're trying to really optimize. But every single case is discussed.
Adolfo?
No, I would say exactly the same, but in individual patient, you need more support. Like, for example, nephrologist, I don't know, your respiratory team, of course, your anesthesiologist, because there are some patients that have, well, special issues. So in certain patient, you need your interventional, your surgeon, and sometimes you need more support to take decisions that are about what you can plan. I mean, it's you need surgeons, you need interventionals, but sometimes you need more people involved.
Adolfo, you always work with an anesthesiologist, the OR? I mean, even
Yes.
in transfemoral with local anesthesia, yeah?
Yes, but we are not using general anesthesia. They did some sedation.
But the anesthesiologist is there, okay.
Is there, and it's the same anesthesiologist that if we have to do open surgeon, they are well prepared to do it. So it's the same anesthesiologist that helped the surgical team during the open surgeon.
Great. Dr. Bear?
Yes, totally agree. One commentary and a question to Dimitri. The commentary is, I like it a lot to do not push the limits. I think when you are starting your heart team, we're trying to get more patients to TAVI, and surgeons, they say, okay, no, this patient is for me. No, it's for TAVI. We're pushing the barriers. But when you have a more confidence in TAVI and have a huge volume, we start refusing some patients for TAVI, and we don't like to get bad numbers, complication. So we say to the surgeon, okay, it's a old patient, but it's a high risk TAVI. The transfemoral is not good. We have to perform a second access. Maybe it's good patient for a surgery, European surgery. So the team planification is totally agree. Maybe in our hospital, our patient comes a lot from the surgery team. Okay, they say, okay, this patient is high risk because of extreme obesity, but for us it's a big speed, annulus, big annulus, aortic in great angle, and we say it's not for me, it's for you. And we start type, okay, the patient is for you for surgery, and no, not for me, for you for TAVI. So the team is going to increase and going to progress simultaneously, probably. And the question is for you, Dimitri, what do you think when you have a complication in the femoral artery? You always perform an open surgery, a graft, or you like or never perform a stent in the femoral?
No, it's a good question. I guess it depends on the patient risk and age. If the patient is extremely elderly and fragile, then we'll try to put a stent in. Or even just dilate the artery and see what happens, and plus or minus stent. Stent is not ideal in the common femoral because the patient, is going to walk and is going to bend and all that. Right. But if we can balloon, do a balloon arterioplasty, we will do it, plus or minus stent. So we don't open every time. However, in this case, I showed a case where we did balloon and it wasn't ideal. So in that case, we had to open. The artery was it's actually they're not easy surgeries because you get there and it's a lot of calcium and you're trying to sew, and sometimes you have to do a long interposition graft and go into the retroperitoneum. And again, we don't get vascular surgery involved. We do them ourselves because we're comfortable with that. So we, as a cardiac surgeon, so we do them ourselves. So yeah, opening the artery is rare. It's rare. Usually after a balloon, you can get the result that you want.
When you are all together in the room, I mean, how do you perform with your interventional cardiologist? Who is the first, the second? How you turn? How do you decide?
Yeah, the other thing we're usually, if it's 100% percutaneous femoral access, both surgeon and cardiologist are scrubbed, and we alternate who does the access and who does the turn, or who does the valve deployment. So we alternate. These cases, so the TF cases go to cardiology. Anything else goes to cardiac surgery, the TC. But again, and we have a lot of fellows that we train that come from interventional cardiology usually. There's a new paradigm now. We're trying to get fellows from the surgical side to train them in wire skills as well, and not call ourselves cardiac surgeons and interventionalists, but call ourselves, all just interventionalists in during the case. In other words, so we just split the cases 50-50 is what we're trying to do, and that's what we usually achieve. And somebody mentioned anesthesia. Anesthesia is interesting because we're trying to instead of we do 3 cases a day, and that's because of nursing issues, and it's Canada. We have no resources. So I don't know if it's similar to the situation in South America, but it's tough to get resources and beds. So we are trying to limit the interventions of the anesthetist. In other words, we do the art line either by the femoral or the radial, and to try to do 4 to 5 cases instead of only 3, and try to keep the cases going. But that's a lot of the time. It depends on the institution, and it depends on what people are used to doing. So anesthetists, we have an anesthesia present at all times.
I have now some questions from the audience that I would like to share. There's a question about cerebral embolic protection. If you use it and when to use cerebral embolic protection. The other question is about the protamine. Do you recommend to use protamine all dose or half dose, or never use protamine after cases, Dr. Dimitri?
Yeah, again, we're in Canada, and as you know, Herman, we certainly are scrutinized by hospital administration for costs, so we have to minimize costs. That's the major limitation for using Sentinel, cerebral protection. The interesting, Sentinel, you do it by the radial, and it's definitely usable. You can use it, but we have not been using it as they have in the US. In the US, a lot of centers are in love with Sentinel, and they use it for 100% of cases. It's not economically feasible for us, and I don't think the data is that convincing that Sentinel should be used in every case. Who do we use Sentinel in? Well, for basilica, 100% we'll put Sentinel. If we're doing a basilica, either single leaflet basilica or double leaflet, we'll put a Sentinel in, and you can see after, when you take it out, you can see the debris from the leaflet laceration. You can actually see it. So I think it's important to use. The other day I used it because there was a patient that we did that had a stroke after the diagnostic coronary angiogram, and so we did a TF and we did the Sentinel. So I think you can use it selectively if you're extremely worried, but we haven't been using it. I think we've probably used it about in 5 to 10% of cases, not more. Protamine, we give about half dose of protamine at the end of the case. Because we're, for leaflet thrombosis and all that stuff, we give half dose.
Well,
excellent.
Me either. Half dose, especially if the patient is taking some, if not taking, antiaggregants, I mean aspirin or clopidogrel. If they are taking, we remove all the heparin, or we use full dose of protamine. And with the Sentinel, we try, because of the cost, and patient has to pay the device, and they pay in Uruguay 10,000. So it is really expensive, and we use for valve-in-valve when we are trying the mitral, so mitral valve-in-valve, mitral valve-in-ring, or MAC. And if we have to combine procedures like basilica, like chimney, or we have to work on the coronaries, and we use a TF sometimes, and you have a shaggy aorta, for example. Femoral arteries are okay, but you have a lot of thrombus and plaques and everything in the aorta. We use the access, but we protect the brain with the device.
Thank you, Adolfo. Dr. Veas, you have a question?
Maybe to finish, we take a lot of good discussion. One question for Dimitri. How many TAVI do you perform in your center, and how many times you have to open a test in the cath lab?
Yeah, so TAVI, we do about 350 to 400 a year. Like I said, 80% are, every time I say this, nobody believes me, but we do 80% TF and 20% alternate, which is high. What does that mean? Well, ever since we've attained that proportion, we've hardly had any vascular complications in the femoral. So it goes to show that I think the really high risk femoral cases are siphoned off to TC. So they never get an opportunity to get a TF complication because they go to TC. So so we do actually 20% TC. Everybody says that's crazy, but that, you know, Herman was here and he saw, you know, but so we do about 350 a year. So complication rates are low in the cath lab. The other thing is, it's not in the cath lab. We have a hybrid room. I think the hybrid room, we've had it now for about 4 years. The hybrid room is very, very useful because you can have a pump that's ready at all times in the hybrid room, and you can do surgery in the hybrid room. And sure, it's not the best place. I mean, my colleagues in cardiology, you know, it's not the best place to do a coronary stent, you know, if you need to do one really quickly after a TAVI, but that's rare. But everything is in the hybrid room. You know, all the balloons you need for TAVI, all the devices. If you need to do a coronary stent, then everything is in the hybrid room. And the hybrid room is in the OR. I forget, did you have another point, Nicolas?
No, the question is, how many complications do you have to get an open surgery?
Yeah, open surgery.
Sorry, because you are in a very huge place with a lot of complicated cases. Not these cases we have a 20% of alternative access.
Yeah, I mean, complicated. So open chest after TAVI is very rare. I think it's less than 2% of cases, and that's because we try. I think it's patient selection. That's the most important thing: selection. And we do these weird things, like, let's say you have a case where you could do like a hybrid case where you have a really tough left main and you have severe AS. Well, sometimes we've done off pump Lima to LED, and through the closed aorta do a TAVI, you know, so transaortic but open sternum. So I've had another case where the patient had a 19 millimeter mechanical valve. So I took out the mechanical leaflet and I deployed an S320 in there through the open aorta. So we do these off-label things, these kind of crazy things, but they're rare. But you really, I think this is where the heart team comes in. You thinking about these patients and not just jumping and really pushing the envelope and doing a high-risk TF. I think sitting down with 6 brains and individualizing treatment to each patient, I think that's what is key to preventing complications. And sure, you're going to have a disastrous complications every now and again. We had one in an 89-year-old recently. We ruptured her annulus. CMAC came in. He helped me out. We did the route it was a 46-minute clamp time, and the patient survived. You know, and it was miraculous. But I got to tell you, from the 11 or 12 annular ruptures we've had about 80% mortality. Even if you do everything right, I mean, sometimes you get in there and there's just free rupture is the worst. Because you get in and there's uncontrollable bleeding, and even if you go on pump, I think this patient is already dead. You know, there's really nothing you can do, and luckily it's rare. Embolization into the ventricle. Okay, yeah, if there's not a lot of calcium, sometimes in a big annulus, you can embolize into the ventricle. That requires surgery. The results are better. LV perforation due to the wire, the LV wire, or RV perforation due to the pacing. We pace through the Safari. I don't know what you guys do. If you guys are putting in a swan.
When we perform a balloon expandable, maybe we use a pacemaker, but maybe in 90% we use evolute or
Sure.
accurate, we perform the basing if necessary by the wire.
Yeah, and RV perforation can be even managed with a pericardial drain. You know, you don't even need to open most of the time. LV, even sometimes you can manage conservatively. Sometimes I've had to put a stitch on the LV, that's fine. So those are kind of but again, annular rupture is really the big one. Annular rupture, I don't know if you look at the STS data, you know, the TCT registry, Dr. Bavaria presented recently, you know, annular rupture is still, even in high volume centers, I think the mortality is over 50%, that's for sure.
Yeah.
Even in high volume centers, I think.
Intra procedure and 1 month is the more huge the number. Yeah. Totally agree.
Adolfo, how do you pace your patients? You put on a transitory pacemaker or through the wire?
Through the wires, I would say 98% of the cases I use the pacemaker when I think that most probably the patient will leave the room with the navy block. No, not another situation. All the others are through the wire. I think it makes sense because the wire is touching or in contact with the ventricle in multiple points. Instead, the pacemaker lead is just touching one point. So it makes sense to have a wire and pacing through the wire. And I have a very good experience using a balloon expandable valve without any problem. So I use in all my cases.
Okay, Dr. Dimitri, you say that someone use or do transcarotid TAVI through a percutaneous access so what do you think about that? Do you think it's necessary to do a percutaneous access through the carotid, or it's always necessary to open and see the artery to avoid complications?
Yeah, I think it's much easier to open the carotid, unlike the subclavian, and we've been proctoring people across Canada to do carotid, and it's always the same comment that I get is that when the team has their first subclavian complication, and it's very hard to get to under the clavicle, and in big patients, they've had their first subclavian catastrophe, then they don't want to do subclavian anymore. So the carotid is very superficial. It's right under the sternocleidomastoid omohyoid. It's right there. I think it really, a 2-centimeter incision doesn't cost the patient much, to be honest. So I think it's much safer to do it with a tiny little cut down. You know, you don't need to cut the whole neck open, you know, I mean, small incision, expose the artery, really fix it by primary to primary repair after the introducer is out. If the artery is small, and I had a question, you know, how small? Minimal lumen, I've done 5 with the commander. Okay, it's a little bit tricky, the commander, because you need a long side table. It's, you know, a lot of the E-sheath is out of the patient. So, you know, you need someone to be holding the E-sheath as you're advancing the prosthesis, and then the alignment happens in the ascending aorta. It's possible, even in a short ascending aorta, you can align the balloon with a prosthesis. So if you have a small vessel, you can do the commander, or you can do evolute. Evolute has 14 French, 16 French, you know, 14 to 16 French. So evolute can be done by you know, completely sheathless. Just remove the sheath, pull it all the way back, and just go in completely sheathless with the evolute platform with excellent results. And you can do commissural alignment by the carotid. But I would expose the carotid for my first cases. I don't think there's any benefit in doing percutaneous. General anesthesia, 90% of our cases were done under general anesthesia. So people complain, well, why general anesthesia? You can do TF without general anesthesia. True, that's very true. We extubate them though in the OR. Okay, they're extubated immediately after. Infiltrate the wound with Marcaine and a local anesthetic, and get them extubated in the OR. I don't think 1 hour to an hour and a half of intubation really is that a bad thing. If the patient needs to be awake for a variety of reasons, then you can do it awake as well under local, the carotid.
Using always the left one, or don't you prefer the truncus?
Yeah,
sometimes at least.
Yeah, no, Adolfo, it's an excellent question. 80% are from the left. And it's just such a nice direct shot to the aortic annulus. It's very, now if you have the trunk, is it sure when the introducer is in, the left carotid is occluded for sure. Sometimes with the trunk, you can have a bovine arch, and you can also occlude, potentially you can occlude the left,
both
the left
carotids.
common, both carotids at the same time. So does that really happen? I've done bovine arches through the right. It's been fine. You're seldom occlusive through. At the end of the case, we used to inject the carotids to see. Not necessary anymore. I mean, what I do is you can do echo with a hockey stick, surface echo, to see if there's intimal flap. I don't do that anymore. I just do a Doppler. If I have an excellent signal, because I see intima. If I have an excellent signal at the end of the case, I'm satisfied. The cardiologist doesn't inject the artery. You can if you want to, but and you don't need really to do echo. But intimal flaps have been extremely rare.
Good. So thank you very much to everyone. I think it's time is over, and really enjoyed to keep learning from Dr. Dimitri, Adolfo. We had really good presentations, and I still have some questions, but we don't have much more time. And Adolfo, it's his birthday, so he has a party waiting for him. Thank you very much. The objective of this webinar was to take some home message, and I think it was really clear: teamwork, discussion, choose your patients, and adapt your approach to the patients, and not in the other way. So we have a lot of things to learn in South America, and we are working on it. And once again, thank you very much, Dr. Dimitri. I know you're working right now in a hospital, and thank you very much, Adolfo, for your time and for spending some time with us even in your birthday.
Thank you very much. For me, it was a pleasure. I think it's a good initiative to have this collaboration with people like Dimitri with a lot of experience. I have to say that I feel envious of how many papers he has published. Sorry to be envious. It's something.
Oh, thank you so much. No, great. Thank you, Herman, for inviting me. It was an excellent presentation, Adolfo, and these discussions are always interesting to see what people are doing. I think only by collaborating we can move the field forward. And the publications are the fellows that we have, including Herman, who was here, were amazing, and the fellows are driven, and despite that they never sleep and they always working, they still manage to write papers, which always impresses me. And it's if I've written so many, it's because I'm part of this great team, which is driven and a lot of energy, and it's really a pleasure and a privilege to be working with them here in Quebec.
Congratulations.
Thank you very much.
Thank you very much to all of you. We'll be in Quebec soon, I think, and hope to see you soon, Adolfo, too. Thank you very much, everybody. Have a good night, and still be safe, please.
Thank you very much.
Gracias a todos. Gracias,
Linda. Muchas
gracias.
gracias.
Thank you, más por organizar todo. Nos vemos en un próximo webinar quirúrgico, probablemente en el mes de octubre, que está por definir el speaker. We hope will be Joseph Bavaria, but I need to wait for the confirmation. See you soon. Thank you. Gracias a todos.
Hasta luego.
Luego. Bye bye.
Thank you.